Welcome to another special edition of PSC Deep Dive, a truly expert analysis on plastic surgery topics. And it's my honor to host this deep dive on breast implants and disease. And we've got three really great plastic surgeons to share some insights with us today. We have Dr. Pat McGuire from private practice Parkcrest Plastic Surgery and clinical instructor of surgery, Washington University in St. Louis. And then we have Dr. Mary Gingras and Dr. Mindy Hawes, both from Nashville, Tennessee, who are clinical professors in plastic surgery at Vanderbilt University. Ladies, I know you're all aware of a couple things that we're going to talk about today. There's been a recent publication of an article in the Annals of Surgery that combined a couple studies. It really has brought up the criticism of quite a few scientists because of citing many flaws in the study. And Pat, I thought I'd start with you, but what did you think about this Annals paper?
Well, the paper had a lot of flaws, and they pointed some of them out in the paper itself, but I think it is important for people to understand the limitations of this study. The first one is that they combined two studies, and these are two completely different studies, different methodologies. You really can't combine two different studies and come up with any scientific conclusion. The second part was, this was a 2-year follow-up in Mentor's post-approval data and 3-year follow-up on Allergan's post-approval data, but the follow-up was only 20% of patients on for Mentor and 60% for Allergan. In the Mentor paper, this was administered surveys to the patient where they could write down self-describe any symptoms that they may have. Allergan did require a physician diagnosis to come up with the conclusions of what percentage of patients compared to the general population would develop specific diseases. That's another potential problem in this study, is that the general population included men and women, all ages, and one of the things that they had noted was an increased risk of stillbirth compared to the general population. Well, if 50% of the general population are male, they're not going to have stillbirths. So that number already becomes a bit suspicious. They had conclusions in it that actually would say breast implants were protective of some diseases such as cancer, fibromyalgia, and rheumatoid arthritis, but patients with implants had a higher risk for scleroderma, Sjogren's syndrome, melanoma, and stillbirth. So all of it is the numbers were different from Allergan than they were for Mentor, and they lumped all these together into a study that actually has no scientific validity at all. And I'm surprised, frankly, that it got published in a high-level journal such as the Annals.
Yeah, and Mindy, so we rely on kind of the scientific merit to basically translate. We take that information and translate, hopefully, to offer patients better outcomes. But the problem is when you have a scientific study like this that has so many flaws, the data is essentially useless, is what a lot of people have claimed and feel like. What are your thoughts on the paper?
My thoughts are, I work as a clinician to stay on top of plastic surgery topics. As a patient who has my own breast implants, I want to stay on top of breast implant science. This paper's not new data. It's analysis from the FDA website of old data, all of it at least 7 years old. So I'm very upset and angered that now, with the publication of this paper in a reputable journal of old data that's been mishmashed together to create a frenzy of fear, that I'm going to have to waste time in my consultation with patients. Instead of talking about the risk of breast cancer that's 1 in 8, I'll have to allay their fears about some minuscule risk of Sjogren's syndrome versus that somehow the implants are going to protect them against lung cancer. I'm upset and very disappointed.
And Mary, you've been a valued educator in our field for many years and used a lot of these data. And I know you're aware of a lot, there's 35 plus studies that have addressed this question over the past 20 years. But I mean, what kind of difficulties do you see this impacting your patient care, and what are your thoughts?
I think this is going to cause unnecessary fear, unnecessary angst in women who have breast implants, who might not be in the scientific, realm that they can analyze the data and understand. It's throwing out information that really doesn't show a cause and effect relationship. And I'm afraid that people are going to interpret it as breast implants cause these problems. I'm in the trenches every day. In my clinical practice, I put a lot of breast implants in. I enjoy breast surgery. I enjoy breast implant patients. And, I absolutely want to be able to give people good data. I have breast implants myself. I am every day interested in good scientific information on breast implants, and I want my patients to be able to come to me for updated, valid information. And I think that this study, so to speak, is giving people unnecessary fear.
Yeah, I think those are some very insightful comments. Certainly, you all have noted a lot of the issues that have been cited. There's a lot more, including what we call confounders, which are when you're doing a study, you have to control variables that can also affect outcomes, which was basically not controlled at all in these studies. So I think there'll be a lot more discussion about this, but I thought, since we're talking about this now, let's talk a little bit just for the viewers. A lot of people have breast implants. And there is, I know each of you has specified recommendations of what you tell your breast implant patients as far as their long-term follow-up, because patients do need to have follow-up. So Pat, why don't you just say a few things about what you tell your patients and what you think is important?
Yeah, when you have breast implants, there's kind of a responsibility that you have to take care of yourself and follow up with your doctor. I see my patients, I tell them I would like to see them at least every other year. We do not charge for follow-up visits on any of our breast implant patients. We encourage them to come in. So I want my patients, if they have any change in their breast at all, I want them to come in and see me as well. Breast implants are not lifetime devices. Nothing man-made will last forever. So especially when they get into the 10, 12, 15 years out, I'd like to see them every year and would like to see them sooner for any changes. I recommend they follow the Cancer Society's recommendations for mammograms, self-breast exams. They need to learn what their breast feels like. You have a new breast after you have breast implants, whether for cancer, reconstruction, or for cosmetic reasons. You need to learn your new normal in your breast. If anything changes in that breast, you need to come in and get it checked.
Mindy, what kind of things do you tell your patients in terms of what they should know about long-term follow-up with implants?
What I tell them is that, just like Pat, if there's any change, I should be your first stop. I can't tell you how many women come to me after being terrified for 6 weeks, getting mammograms and ultrasounds, and it's a fold in the implant, or it's the edge of the implant, or it's a wrinkle in the implant. I can really shortcut the anxiety. I also have patients who've come to me that I've helped them diagnose their breast cancer. So long-term follow-up, I agree with Pat. I recommend every year. I don't charge for those follow-ups. I personally like to pat myself on the back about how the breasts still look great and get those pictures. But more importantly, I want to maintain a relationship, so if something comes up, I see it. I had a woman today that I just changed out her saline implants. She got them 44 years ago, and one finally ruptured. She's 66, so she's planning on this set taking her on home. But I tell them, chances are they probably won't be. If you care about your breasts now, your body's going to change. You're going to care in 40 years.
Mary, anything to add on the long-term follow-up side?
When I see patients back at 2 to 3 months, the majority of the swelling is gone, and I can then show them how to do a self-breast exam on their own breast, and I can tell them, now this is the implant. Most of the time you can feel the implant. I show them this might be the valve of a saline implant, and then I again offer to see them once a year at no charge or every couple years. I definitely recommend that they get mammograms according to their normal recommendations, which may be a little bit different if they have a family history or personal history of breast cancer or breast disease. Mammograms and ultrasounds are really quite specific for picking up ruptures or other pathology. So I teach them what they're looking for. When I show them how to do self-breast exam, I encourage them to get mammograms according to normal schedule. And I tell them to come and see me. If they notice anything different, I'll be happy to field it and get them pointed in the right direction. But breast implants require some maintenance. And when I am discussing with them whether they want saline or silicone, we talk about the fact that there's a little bit different maintenance with silicone versus saline. I call saline a little bit lower maintenance because if you do have a rupture, it goes flat. It's like you got a flat tire. You call me up and say, get me on the schedule, I got a flat tire. On the other hand, if a silicone implant ruptures, you might not know about it. And there's terminology being flipped around, silent ruptures, and this paper also kind of makes, I think will give women some anxiety about silent rupture. Well, the data, we have lots and lots of studies showing that ruptured silicone implants do not cause disease.